Case 9. Chest CT has greater sensitivity as compared to RT-PCR in diagnosing COVID-19, but it lacks specificity. There has been a lot of debate on using a CT scan as the front-line screening tool for diagnosing COVID-19. In fact, CT findings begin to appear even before a positive COVID-19 lab result. The characteristic CT scan findings evolve in 5 different phases are shown the figure. Prior to symptoms onset, within 1 to 2 weeks of exposure, CT demonstrates bilateral, scatters ground glass opacity. Within 1 to 3 days of symptoms, CT scan shows ground glass opacity plus irregular, interlobular septa. Within 3 to 7 days of symptomatic presentation, CT shows ground glass opacity, irregular, interlobular septa and consolidation. After 2 weeks, clinical symptoms, CT shows lung fibrosis and decrease in size and density of consolidation. About 2 to 3 weeks after symptoms, healing and repair response within the lungs shows patchy consolidation and septal thickening. It has been observed that CT is more sensitive to detect lung parenchymal changes compared with X-ray and ultrasound. Case 10. RT-PCR test for COVID-19 was performed on symptomatic patient in nasopharyngeal swab and cerebrospinal fluid. Although, the specific SARS-2 RNA was not detected in the nasopharyngeal swab, it was detected in cerebrospinal fluid. Brain MRI was performed 20 hours after admission to the intensive care unit. MRI showed meningitis and encephalitis associated with SARS-2. This case showed the neuroinvasive potential of the virus and that we cannot exclude SARS-2 infections even if the RT-PCR test for SARS-2 using the patient's nasopharyngeal specimen was negative. In the brain, ACE2 is expressed only in endothelium and vascular smooth muscle cells. Coronavirus may invade brain via ACE2 receptors. MRI demonstrated the abnormal endings of medial temporal lobe including hippocampus suggesting encephalitis, hippocampal sclerosis, or post-convulsive encephalitis. Finding the suspected patient is the RST step of a preventive measure against the pandemic. It should be kept in mind that the symptoms of the encephalitis or cerebropathia may be the RST indication, as well as respiratory symptoms, to ND the hidden SARS-2 patients. MRI scan showed following abnormalities in the brain. Figure A diffusion-weighted images, DWI, showed hyperintensity along the wall of inferior horn of right lateral ventricle. Figure B and C fluid attenuated inversion recovery, FLAIR, images showed hyperintense signal changes in the right mesial temporal lobe and hippocampus with slight hippocampal atrophy. These findings indicated right lateral ventriculitis and encephalitis mainly on right mesial lobe and hippocampus. Figure D T2 weighted image showed paranasal sinusitis. Case 11 and 12. Brain MRI in 2 critically ill SARS-2 patients with persistently depressed mental status including a 56-year-old man, image A to C, and a 64-year-old man, image D to F. Axial diffusion weighted, A and D, apparent diffusion coefficient, B and E, and FLAIR, C and F, images at the level of centrum semiovale in both patients demonstrate symmetric diffuse T2 FLAIR hyperintensity, arrowheads, and mild restricted diffusion, thick arrows, involving the deep and subcortical white matter with relative sparing of juxtacortical white matter, thin arrows, in both patients. The restricted diffusion on DWI is more conspicuous than the T2 FLAIR hyperintensity. Restricted diffusion results from failure of energy-dependent ATP production in cell membranes resulting in intracellular cytotoxic edema, usually implying cell death. Less frequently this MRI abnormality is seen with other conditions including neoplasms, intracranial infections, traumatic brain injury, and demyelinating processes. T2 FLAIR hyperintensity reflect lesions produced largely by demyelination and axonal loss. Case 13. T2 weighted MRI images of SARS-2 positive 64-year-old man were acquired. Image A was acquired 1 week before the current hospital encounter and during workup for headaches. Image B was acquired after 23 days of mechanical ventilation in the ICU. Image B shows multiple juxtacortical punctate microhemorrhages in bilateral temporal and right occipital lobes, small arrows. Fully integrated biograph MMR, PET MRI, could provide a clear benefit in particular applications requiring multiparametric imaging capabilities, high soft tissue contrast and lower radiation dose. Various studies demonstrated feasibility of simultaneous PET MRI in many clinical applications. PET MRI is yet to be investigated to access physiological changes in SARS-2 infection. FDG PET MRI would visualize inflammation in the lungs, brain, and myocardium. It would acquire additional MRI data such as blood perfusion, demyelination, fiber tracking, and neurometabolites in the brain. It would be useful to access structural and physiological dysfunction in the lungs, brain, and heart. Low radiation dose involved in this technique compared with PET-CT would make it useful in pediatric imaging. This slide is my personal opinion and may contradicts with yours. In the first week of April, confirmed cases of SARS-2 in the USA were 200,000, which was 100 times more than India. In the USA, rapid spread of virus in flu season might be due to influx of symptomatic and asymptomatic migrants, before and after Chinese Lunar New Year January 25, 2020. Installation of thermal cameras on various airports screened outgoing symptomatic travelers and quarantine incoming passengers in the USA. Cancer, diabetic and cardiac complications are the leading health problems in the USA. These patients are more prone to SARS-2 infection, which increased fatality cases. However, massive COVID-19 RT-PCR test in various cities helped to isolate symptomatic as well as asymptomatic carriers. Quarantine and lockdown methods controlled further spreading of virus in the USA. Now, the cumulative graph of confirmed cases is reaching plateau. In case of India, although travelers coming from China screened out on airports, they were skipping passengers coming from other countries. As the lockdown in foreign countries in the Middle East and Europe began in March and April, many symptomatic and asymptomatic travelers migrated back in India. These passengers were not quarantined and disease started spreading rapidly, especially in the mob, metro crowd, unhygienic slums and religious gatherings. India did not launch random massive RT-PCR test in the cities, and therefore, it is hard to find COVID-19 carriers. India is now in unlockdown phase, and due to free movements of untested asymptomatic carriers, the cumulative graph of confirmed cases is becoming linear and adding more positive cases every day. They say, nothing is perfect in this world. By that statement, health system of any country is not perfect, and coronavirus exposed a broken system. Jnanesh obtained PhD degree in pharmaceutical science from Institute of Chemical Technology, University of Mumbai. He completed postdoctoral studies at the National Institutes of Health, Bethesda. He started working on evaluation of radio tracers for brain imaging at the National Institutes of Mental Health, and also contributed on research projects from NINDS and NCI. After completion of postdoc fellowship program, Jnanesh worked with Johns Hopkins University School of Medicine, Baltimore, Schering-Plough Corporation, Singapore, Columbia University Medical Center, New York City, Stony Brook University, Department of Biomedical Engineering, Johns Hopkins University. Jnanesh is contributing in translational molecular imaging field over the past 17 years. He is interested to investigate applications of multi-imaging modalities in multiple species to find the right answers to the clinical needs.